Hello everyone. This is Dr. Sina Saygılı from Turkey. Today's show will be about digital impressions. Dr. Faraj Edher will be with us today, and we will ask him 10 questions, and we will discuss every single point of digital impression technology and the brands, actually. So you can find the previous shows on YouTube, on mainly on Turkish, of course, my streamings, but there is a one that you shouldn't miss out with Dr. Devigus. So I would be happy if you could see and click on the video as well. So on Friday, Dr. Kochman will be with me, and we will discuss about the digital smile design, of course, and the Orofacial Club. So I would like to welcome Dr. Faraj immediately to the show. Welcome, Faraj.
Thank you, Sina. Thank you so much for having me.
I just would like to express my my friendship with you. Actually, like before that, we met in Italy in one of the meetings for the International Association of Dental Students. That one of my first congress actually, which I attended internationally. And since then we are still in contact, and you've been in Istanbul once, and then I think we've met one of the FTI congresses as well, or one of the IADSs. I don't remember.
Yeah, I know we met in the. I've been to Istanbul twice, where I think we got to meet, and then the Italy. Were you at the Poland one, the one in Poznan?
Yeah.
Yeah, I think we saw each other there too. But it's amazing. What a small world, and yeah, I'm glad to be here. I think what you're doing is great and very useful during this time.
Yeah, I mean, we just try to share our knowledge and experience through the digital world because of our age level. Let's say we are the young professionals, let's say, but we are just easier to adapt for the digital technologies. And as we are knowing you that you are just really taking care of those technologies into daily life and sharing your passion with other professions in worldwide with the Digital Dentistry Institute. I would like to just first ask you to introduce yourself shortly, not typical resume, of course, and tell people who you are and what you are doing.
Sure. So my name is Faraj Edher. Like you said, I'm a prosthodontist, and I practice in Canada. So I'm in Vancouver, Canada. And like you said, I'm very passionate about progression. And I think one of the things that's allowing our profession to progress is the use of digital technology in how we treat our patients. So I'm very passionate about finding ways that we can do a better job more efficiently, more effectively, more predictably, so that ultimately we treat our patients better. So in addition to being in private practice, I spend a lot of time as the director of the Digital Dentistry Institute that you mentioned. Our focus is to really provide world-class education for dentists all around the world. So we do our courses in Canada, the US, UK, Dubai, India. And what's amazing to see is that this is a joint movement. It's not in one place or one city. It's all the dentists around the world, especially like you said, the ones that know that they're going to be in dentistry for many more years to come, realize that this is the future of what we'll be doing and realize that there's a huge advantage to it. So I do a lot of that. I also teach at the university here. I'm a clinical assistant professor, so I teach there part-time, and I'm involved in how can we integrate digital technology into the curriculum for dental students.
Very nice. I mean, you are your kind of people who are contributing to dentistry in this way. I think they are really valuable, and we should be listening them much more into this kind of events. And this is really interesting because you are probably one of my guests that I talk to, probably most distant one. And in Canada, I think it's 11 a.m. right now, right?
Yeah, it's 11 a.m. here.
And it's been like already sundown in Turkey, and it will be really mood changing that you are in the morning, probably more powerful, more energetic, but I'm a bit tired, as you can see on my eyes, maybe, probably. But I think we will cover the show with a good tempo and good quality that first thing that I would like to ask actually about digital workflow and also digital impressions. The process is hard or not, or the learning curve. How you can define this process?
That's a very good question, because in my opinion, the main reason why we aren't all using digital dentistry is two things. One is what you mentioned, which is the learning curve, and two is the cost barrier, that it's expensive sometimes to get some of the equipment. But the way I think of it is very similar to any tools or technologies or new techniques that we try to do. We have to understand that there is a learning curve. And, if we judged any sort of new, let's say, composite material based on the first time we use it, we would never use any materials, because, with anything we start doing, we'll find difficulties and challenges, and it just takes a little bit of time to getting used to it. The same applies for digital technology. If you're using a digital impression or an intraoral scanner for the first time, it's not going to be easier than the conventional PBS. It's going to be more challenging. It's probably going to be more time consuming. So you have to understand, everyone has to understand that there is that learning curve. And just like with anything else, practice is what makes it easier. So doing more of these procedures makes it easier. The challenge really is that with digital technology, you also have to be to some degree technologically savvy. So you have to be comfortable with keyboards and mouses and screens and things like that. So that's why I found with my experience that the younger generation of dentists who are used to laptops and phones and smartphones and these things find it a lot easier to adapt to digital technology than maybe the people that are towards the end of their career or have been doing this for 30, 40 years who aren't comfortable with a laptop. So it's going to take them a little bit more time to become comfortable with using an intraoral scanner. So that's kind of one of the issues that is dealt with. And the other thing is choosing the cases. If you're starting to use an intraoral scanner for the first time, it makes no sense to be doing a full mouth impression of crowns using a digital scanner for the first time. I would start with a single crown or maybe an inlay or an onlay. So finding the right procedures to test something is definitely the way to do it. And then just trusting the process and trusting the fact that it will get better. Over here, I don't know what it's like in Turkey, but over here, there's a lot of dental clinics that have an intraoral scanner. They've used it once, was difficult. Used it twice, was very difficult. And then they put it in a corner, and you go see them after a year, and they say it doesn't work. That's where I think we have to slightly shift our mindset to the fact that this doesn't differ from anything else that we do, and it takes a little bit of practice for us to, become comfortable and efficient with these tools.
The same happened here in Turkey, as you mentioned, that the Sirona Serek system was really popular, and not really all dentists managed to do all this the process, impressions, designing, manufacturing, and then they just left it somewhere in the corner in the clinic. So it's already scientifically proven that younger generation just can use those technologies much easier. So I think it's really important what you say. It mentioned that people are just buying those technologies just to find a miracle maybe, but it is not like this, and it's still a tool that help us our job to make it easier. So that's why there's a learning curve, and we should be just pushing and practice is the key for success, I think. And
absolutely. Yeah.
But when you face those challenges and you complete that, okay, I can use this tool very well, but what will be the challenge for the fixed prosto, let's say? How you change your preparation strategies, like how you change your prep, how you define your bevels, or what you can say about this?
Yeah, so that's another good question. The thing about these intraoral scanners is that they shouldn't limit what we do clinically. Like you said it perfectly. These are add-on tools to make our job easier, to make our job more predictable. and that's the way they should be thought of. There shouldn't be compromises to using them. So regarding crown preparations, one thing for me, before I get into a little bit of the details, one thing for me that I've realized is using an intraoral scanner has significantly improved my crown preparations. Not because crown preparations have to be better when using an intraoral scanner, but because when you're able to scan and then zoom in on your prep in real time and see the margins and see the smoothness and see the things that aren't smooth, it allows you to get instant feedback as to how you're doing things. And then over time, you begin to change things to improve. So it's a great tool for self-assessment and feedback that you can do right on the spot. The limitations that you're asking about, I don't necessarily think of them in terms of prep design limitations or anything like that. To me, in my mind, the design of my margins and prep is based off of the material that I'm going to be using. Not necessarily how I'm going to capture the margins, but what am I going to be placing on those margins. So the same protocols for preparation that I'd use for lithium disilicate Emax crowns, whether I'm doing a PVS impression or a digital impressions, the criteria are the same. Same for zirconia, same for metal ceramic, same for any other material that we're using. The limitations that we do have in fixed prosthodontics on teeth, at least, is that the camera can only see what your eyes can see for now. And I think we'll talk a little bit later about the future and what's to come. But for now, all of these systems use some sort of light or laser to be able to capture something very similar to the way a camera or a video recording device does. And the limitation with that is if you have a deep margin or a hard to access area like the distal of an upper second molar or a lower second molar, for example, that can become an issue because with PVS, we get the flow, right? So if you have a deep margin, even if you can't see it with your eyes, you squirt light body in there and then you pick it up with heavy body. So you're able to get advantage of that flow of the material. That's one of the limitations, in my opinion, with intraoral scanners. It's that there is no flow component. What you see is what you get. So you have to choose the cases wisely. I would say I use a scanner more than 90% of the cases. The cases that I don't use it are usually those where there's a previous crown that's really deep, extensively subgingival, very hard to retract and see, deep caries, things like that. So in those situations, we do have that sort of limitation when it comes to what the scanner can see.
The very, very, very important thing that the impressions that you can see on the screen will really improve your preparations and what you do actually as the same as the digital photographs. And the second thing I would like to ask you, what do you think about the shoulderless preparation and digital impressions? Some of the authors says it is possible to capture everything, but some of the authors says you should always go for a chamfer or some sort of horizontal prep. What do you think about this?
Yeah, I too agree. The reason I agree is because we know that the materials we use nowadays, most of the materials used nowadays, don't necessarily require a shoulder preparation. So they do well-rounded, smooth shoulder, especially if you with bonded restorations and like that. So the material restriction doesn't exist. But when we talk about digital impression, one of the things that is very true because of the way the technology works, it depends on light reflection. And when you have sharp angles, it becomes difficult for the scanner to get the light to those corners and capture them more effectively. So there have been studies that have shown that rounded angles do provide with more accurate marginal fit because the scanner is much more likely to be able to pick them up accurately.
I definitely agree on this point. And for the limitations, as we mentioned before, but for daily use, what do you see as, not on the preparation level, but what will be your limitations for daily use in general?
The limitations on daily use right now with the new scanners and all of the advancements that they have done are really only in capturing soft tissue. So it's still, I mean, I'm working with some companies in beta testing being able to use an intraoral scanner to capture an edentulous arch for a complete denture. So it is in the process of working. It's not there yet, though, so it's not mainstream yet. I've done many complete dentures using an intraoral scanner. I know many people who have with predictable results, but it's still quite challenging to do because the way these scanners work so far has been that if they detect movement, so if they see saliva, blood, tissues moving because of the tongue or the cheek, they stop scanning. One thing that we want to do a lot of times during removable complete dentures or anything with soft tissue is we want to capture functional movement. So there's that disconnection there. But that's something that's being worked on. So I would say limitation is large edentulous spans. So whether it's a partial denture that has a large edentulous area or complete dentures. Also with implants, if you're trying to make a full arch bridge on implants or even a bridge on two implants that have a lot of distance in between them, there's still a limitation there. Because the other thing that everyone has to understand is how these machines capture the information. And even when all of these new scanners say they're video capture, they're still taking many still images after each other and stitching them together. Now, this is an algorithm that's stitching these things, that's connecting these images together. And that algorithm needs to find common points so it knows where to continue scanning. It's easy with teeth because we have anatomy and morphology and pits and fissures and all that sort of thing. It's much more challenging with gums and gingiva because sometimes it looks the same. So it's very difficult to know where you are and where you stopped. That's why the roof of the mouth, the palate, is easier to scan because of the rugae and the raphe and those landmarks that are there. But if you're talking about just the buccal mucosa or just the alveolar ridge, that's a little more challenging for the scanner to distinguish and be able to stitch. But I personally believe that within the next 12 to 18 months, we'll have upgrades in scanners that allow us to do that very predictably.
The video capturing is really, as you said, not really defined as we are imagining. And 3Shape actually introduced some of the features that patient-specific motion, that it records a video of the tooth movement and then exports us jaw movement mimicking something like a document. So maybe with the soft tissues, with the functional movement, border movements, we can record the videos and it can be maybe a solution. But nowadays, as you said, it is not really something to go for it very easily. So as you mentioned right now, that's for the full arch scanning. What do you think about it? Like, can we do full arch restorations for the dentate basis or implant basis? Like, what do you think about this?
For dentate cases, so if you're doing a full arch reconstruction on teeth, I absolutely think we can. There's lots of evidence that shows that we can, that the accuracy is there. In my opinion, it's actually more predictable than using PVS because with PVS or any other material, you're taking everything in one shot. Whereas with an intraoral scanner, you're able to focus tooth by tooth or section by section and really make sure you capture the details of the margins and the preps and all that as you move across the arch. So in other words, you don't have to remove all your retraction cord at once and take a full impression. With a digital impression, I can remove 2 teeth, scan them, remove the other 2 teeth, scan them. So to me, it's a lot more predictable, especially with these newer scanners. If you're using a scanner that's 6-7 years old, then obviously the limitations that existed then still exist. But with today's scanners, there's a lot of scientific evidence. Most of it, to be fair, is benchtop. Not a lot of clinical studies have been done to look at this, but there's sufficient evidence in my mind for us to be able to do this predictably on teeth. The problem, like I said, is with full arch implant cases. That's where there's still a question mark. For me, like I said, I do a lot of testing. And usually when I test, I'll verify everything to make sure that it meets what I consider or what we consider to be a gold standard. But with implant impressions, so far what we're finding is that it depends on where you're positioning your restoration. So in other words, if you're working on implants and trying to build a full arch restoration, going into the platform of the implant, we are not even close to being accurate enough to doing that with intraoral scanners, because those connections are so precise that when you add up the errors that occur over a full arch, it's very challenging, if not impossible right now, to achieve a passively fitting restoration. However, if you are building up to a multi-unit abutment, for example, what's the norm in Turkey? Do you usually, when you do full arch restorations on implants, do you build off of multi-unit abutments with external connections, or do you build right into the implant?
It depends on the restoration that we are going for. Like for hybrid restorations, we usually use the multi-unit abutments, of course, but we also do a lot of cemented restorations. So for that, we
Yeah.
use the stock abutments a lot because of the cause of the
Yes.
pricing, of course.
And then so you have the stock abutments, and then you have a cemented restoration that you cement intraorally onto them.
Yeah.
Yeah. So in both those scenarios, those are two solutions to improve the chance of getting a passive fit. Multi-units give you an external connection that you're able to have some wiggle room to. Cemented restorations obviously have spacers, so there's some wiggle room to them too. So in those scenarios, the evidence is showing that newer intraoral scanners are accurate enough to allow for passively fitting restorations on multi-units. And of course, with cement, we know there's some give to it, so it'll be passively fitting too, because the stock abutments are stock abutments, so they're going to have a precise fit to them. So the most recent evidence is showing that we're close. Again, I would say, because we have to follow evidence-based dentistry, for me to be comfortable to do this on a daily routine basis, I would still want to see more evidence on the long-term effect of things. But I am comfortable doing it. I do it routinely. I still verify my passive fit every single time, though. But I do the same for PVS impressions too. So I think as long as you're verifying, you can do that as well.
Like every time we go for a full arch restoration, we just have to first check our fit before we do all the restoration and everything, of course. And your patients, what they think about it, like what their perspective on digital impressions mainly.
Yeah. Well, I'm still waiting to meet a patient who I do a digital impression on, and they say, I miss the old stuff. I don't think we'll ever see that. So every single patient who experiences the two will prefer the digital technique. It's so much more comfortable. It gives such a better patient experience, and there's so many studies that have been done to prove this in terms of surveys for patients and what they perceive in terms of a quality of a procedure. So for me, it's a no-brainer. Patients prefer that. But one thing that I think is sometimes overlooked is it's not just the comfort of the patient in the chair. There are so many other benefits the patients get from this technology, such as communication. It is so much easier for me to communicate with a patient when I can show them their teeth on a screen in 3 dimensions and be able to rotate things and show them different dimensions and say, okay, you can see this is where I'm saying your tooth is fractured, or you can see this is where there's been super eruption. You can see that it comes down compared to the other teeth. So having that sense of communication, in my opinion, makes it such a better experience for the patient. Plus, we really get informed consent because they truly, at least they're closer to truly understanding what we're trying to explain to them. In addition to that, patients get impressed, right? Patients automatically trust you more. Whether that's right or wrong, it's the truth. And I think all of us are like that because patients think, well, if this person is using such advanced technology, they must be able to give me a better result. And unfortunately, that's not necessarily true because we know that bad dentistry is bad dentistry with PVS, with intraoral scanners, with whatever it is. But there is that perception too. I feel like patients trust me more when they see that I'm using the most advanced technology for them, when I'm able to communicate with them and so on. So I think it definitely plays a big role in the patient experience, but most importantly, it transforms patient communication.
If you're a bad driver, so Formula One cars
Yeah,
will not
exactly.
save you on the traffic as well. So I totally agree with you on this
They
matter.
they might actually kill you faster,
Yeah,
right? So
definitely,
yeah,
definitely. Do you did I have two more side questions for you. Like, firstly, when I scan the patient, I just use a lot of facial scanning and using it for my restorations, for wax ups and stuff. And one of my patients asked for the face scanning document, and I sent her the scanning, so just to keep it. And one of the patients asked the STLs just to keep it, just to have it inside the house. What do you think about, like, did you have any kind of patients that wants the record of what you are having on digitally?
yeah, a lot actually, and I have started to encourage it. Um, it's funny. You mentioned it. It's not a digital dentistry is not a shortcut. In other words, what we're talking about, which is sending to patients, is something that I do routinely, and I'll tell you why. But before I do it, I've understood that it's a double-edged sword because you can be over-promising, right? A patient can come in, and on a computer, you can give anyone a beautiful smile. Whether you are able to replicate that or not depends on being able to diagnose properly, know what's feasible, what's not feasible, treatment options, treatment plan. The basics of dentistry, restorative dentistry, whatever it is, are just as important as they ever were. But if you're able to account for those things and what you show on a digital smile design case or a virtual smile design case, what you're able to show the patient is realistic, I think it's a great communication tool. It gets the patient motivated, it gets the patient excited. Here in Canada, any records of the patient are their property, so they have the legal right to have all those records, whether it's photographs or STL files or models. Those are the patient's property. Their file and is their property, so we have to give it to them. I've actually, like I said, started encouraging patients. The reason being, like I said, it motivates them. It gets them excited and happy about treatment. I know that what I'm giving them is planned thoroughly, so I'm not worried about it being unrealistic. It's like I'm giving them a model with wax on it. You can also make a wax model as unrealistic as you want if you didn't pay attention. So I make sure that what I'm giving them is realistic, something that I know that I can predictably achieve. And if I have any doubts, I've expressed that to them. I've expressed what the challenges are and so on. But it's also a great referral tool. Because you know what that patient's going to do? They're going to send that video or image to their friends and their family. And they're going to say, hey, look at what I'm doing. Look at this. This is such a cool thing. I can look at my smile. I wonder if it's going to look like this or not. And that's one of the best, word of mouth marketing tools that you can have, especially if after all that is done, the patient gets a nice result. Then I believe that that's something over the long term will certainly be a very valuable tool for me and anyone who's doing it in terms of word of mouth marketing to the patient's friends and family members.
It's like there is no such a bad side of this technology.
I don't know about that. I don't know about that. I think that's one of the things that gets people disappointed. There definitely are bad sides. One of the biggest bad sides, in my opinion, is your computer crashing. Your tray can never crash. You can always take a PVS impression. It's happened to me sometimes. For example, with technology, you're reliant on your computer, so you can be in the middle of an impression and then something happens and your computer gets stuck. So there are definitely limitations when it comes to it, like these technical issues, like we said, the learning curve, and then the cost, right? Because that's also something that, like, all of us who run clinics are to some degree running a business of some sort. So is it worth the investment? What's the return on the investment? That's definitely something that everyone has to analyze and see if it makes sense for them.
Definitely. How about occlusal records? Like, how accurate are they?
In summary, they're very accurate. I can say that confidently because that's what I did my Master's of Craniofacial Science on. So I spent 3 years researching virtual occlusal records. And I've done a study, and then my colleague followed up on my study, and we did a clinical application to it on patients, testing whether the bite scans that you take using an intraoral scanners are as accurate, more accurate, or less accurate than a PVS or a silicone type of bite registration material. And what we found is it is as accurate, if not more accurate, with some tips that you have to know how to take the bite scan properly. So one of the things, for example, that we have to think of is less is more when it comes to virtual bite records and when it comes to scanning in general. So what that means is, like we said, there's stitching that occurs at all times during your scan, whether you're scanning the arch or scanning the bite. So those stitching techniques have to some degree an error in them that occurs. The more stitching we do, the more errors there's going to be. So what we found is that quadrant scans provide more accurate occlusal records and accurate occlusal contacts than full arch scans, because we're introducing more errors to that. I'm talking about the scan themselves, not the bite scan. So if I'm doing a single crown, 100% of the time right now, I will only take a quadrant scan. I will never take a full arch scan for a single crown. The reason being, I'm introducing more error. And those errors might not affect the margins, right? Because the margins will be captured accurately, but they will affect how those two virtual models are articulated together when I take the bite scan. So less is more when you're taking your actual scans. Where you take the bite scan is extremely important. So what happens is you take a bite scan. The bite scan has to cover at least 3 teeth. So you have to capture at least 3 teeth for the upper and the lower. What the algorithm then does is it finds common points and puts them together using something called a closest fitting algorithm. And from that area, it will shift things. So if you have less area so preparing a molar, my bite scan will be focused over the molar area. If I'm preparing a canine, my bite scan will be focused on that canine area. But it has been shown to be very, very accurate because it also doesn't depend on transferring anything. I'm not pouring a model. I'm not transferring the model onto an articulator. I'm not putting them together with hand articulation or a bite registration and then removing it. So there's a lot less transfer, which means a lot less error that's introduced.
That's a really nice tip that you give for the people who are listening. What do you think about actually different brands of intraoral cameras? Are there really high level of differences, or just they're almost the same? Which ones did you try out so far?
So I've used many scanners. I've used the Cerex scanner. So I've used the RedCam, the BlueCam, the OmniCam, and the PrimeScan. I've used the Trios 3 and the Trios 4. I've used the Itero. I've used the Dental Wings scanner. I've used the Medit scanner, and I've tried in exhibitions and stuff a lot of other scanners. So there's definitely a lot of them out there, and they do differ. So they do differ in speed. They do differ in accuracy sometimes. They do differ in user experience. So very similarly to how, if you're using an Apple or an Android, it's a different interface. So some interfaces are just easier to use than others. So user-friendly interfaces, they do differ as well. Most importantly, they differ in their add-ons. All scanners will allow you to scan and send an STL file. Almost all of them will allow you to export an STL file now. I think all of them will allow you to export an STL file. So that basic function is there in all of them. But then there's a lot of add-ons, things like, is it color scanning or is it not colored? Can you take HD photos of the preps to help the lab identify the margins, or do you not have that tool? One of the most powerful tools, in my opinion, is being able to trim away areas that you want to rescan, and also being able to lock surfaces that when you do rescan, you don't want to change. Very useful in capturing margins, because I can lock that surface and I don't worry about the gingiva. So those additional tools and add-ons and features differ from one scanner to another scanner. That's internal features. We also have external features that differ. So some scanners, like for example, if we talk about 3Shape, which is what I use most commonly, the Trio scanner, it also comes with, you can add smile design feature to it. So I can do chairside 3Shape smile design on my intraoral scanner machine with the patient there. It talks directly to my 3Shape, because our in-house lab has a 3Shape lab design, so it talks seamlessly with that. I can integrate it with 3Shape Implant Studio, so then I can also plan where I want my implants to go for guided surgery. So the network is important, in my opinion, too. If I were someone who did a lot of Invisalign, iTero would be a great scanner, because iTero has a partnership with Invisalign. It doesn't mean that you can't send a 3Shape scan to Invisalign. It's just that you'll find that the user experience is easier with iTero because of that partnership. I believe, and I heard you'll have Dr. Coachman on soon, so DSD, I believe, now has a partnership with iTero. So I'm sure there's ways that they've made it easier for you to integrate your scan to DSD because of that partnership. So one thing that I always tell people to do is, first of all, make sure the basics are there. Make sure accuracy is good. Make sure that bite registration is accurate. Make sure that it gives you the things that you need. But then start looking at the internal features. Start looking at how you feel and are comfortable using it. And then start looking at the ecosystem that you have. You may find that one scanner fits into your ecosystem a lot easier than another scanner. So that's the thing. Go ahead, yeah.
Yeah, you just go ahead. No problem.
No, I was going to say, if you ask me about specific brands, in my opinion, there are three, and I'm a little bit biased, not because I'm supported by any of them, but because those are the ones that I feel the most comfortable using. But in my opinion, the 3Shape scanner is a great scanner because they're very innovative. So like you said, they're the first ones that usually come up with some of the really cool features, like dynamic tracing of a specific motion for patients, artificial intelligence to be able to detect caries, things like that. So they're very innovative. Of course, that comes at a disadvantage with cost. They're more expensive than some other scanners. So 3Shape is a good one in my opinion. CEREC is the godfather of intraoral scanners. They were the first one. They've been around since I think the late 70s or 80s, and it's no one can argue that it's a great scanner. The Prime Scan, their new one, is a very nice scanner. A scanner that I'm very interested in is the Medit scanner. It's based off from Korea, and the reason I'm interested in it is all the studies are showing that it compares to CEREC and 3Shape in terms of accuracy, but its price point is significantly less. So it's approximately, I think, 30 to 40% cheaper than those, level 1 scanners. And if you're able to get the same results with that lower price of entry, to me, it's a great thing because it removes one of the barriers for a lot of people to enter, which is the initial investment.
I think the main, let's say, skillful devices are almost the same, but the software makes the difference, as you said. One of the tools that in 3Shape that I mostly like is to trim and rescan and zoom on this area. That is like really life-saving for me, because either I do an impression and if it fails at one corner only, then I have to just remove the area and just rescan for a second. This can't be done for a physical impression, and none of the other digital impressions can give this opportunity for me as well. Maybe in CEREC, there is one way to trim, but I mean it's not that easy as tree shape. So that's why I mean the software makes the complete difference, I think.
Absolutely. Yeah.
But what do you think about the next step for digital impressions? Like the limitation of the soft tissues and, of course, the reflection methodology that is really not really liking the blood and saliva. So, what will be the next step for digital impressions?
The next step in the short term is going to be improving the technology that we have and improving the algorithms to be able to understand. Once the algorithm understands what the challenges are, and if you're able to program it in a way that it understands them, we're going to be able to find solutions to them. So in the short term, I think it'll be improving what we have to make it work better in the situations that are challenging. In the long term, in my opinion, the future of intraoral scanners is ultrasound technology. So this is already in the research phase. There's no applications for it in the market, not in dentistry anyways, and it's still in the research phase. But the research that has been coming out in the past 12 months has been very, very promising. And I see the future being, instead of using light or laser to capture your digital impressions, we'll be using ultrasound technology, maybe in a combination with light as well. And that's a game changer because all those challenges that you just mentioned are gone, right? You can scan through soft tissue, you can scan through saliva, you can scan through blood. And initial studies have been done where they were able to take a crown preparation on a model, cover it with soft tissue, and use an ultrasound intraoral scanner. This was done on a benchtop, but an intraoral scanner to scan it, and they were able to capture the margins through the soft tissue. The only problem was it wasn't accurate enough. So the degree of error, I believe, was around 200 microns, which is not clinically acceptable right now. But that's today. I assure you, in a year, that error will be 100 microns. In 2-3 years, it'll be 50 microns, and then will be comparable with what we consider to be our gold standard. So that is the future. And for me, I honestly can't wait because I'm optimistic that it'll come at a time where I'm still in my prime. So I'm doing a lot of dentistry. And at that point, there's no such thing as retraction cord. There's no such thing as retraction paste. You prep a tooth. You care about the prep design. You obviously care about the soft tissue for other reasons. But then you just scan and you're done. So that's a game changer for anyone who does a lot of restorative dentistry.
That will be the ultimate goal for us, like to change our workflow forever. But then, what do you think? Like, if this gonna change, does it worth for to pay those prices and buy a device now, or just maybe let's wait for a little more?
Yeah, that's a good question, and I don't think it's gonna happen anytime soon. So this is my predict because it doesn't even have a clinical application yet, not even in testing phases. So I don't see us having ultrasound technology and intraoral scanners for at least another, in my opinion, 5 years. And in 5 years, whatever investment you make on an intraoral scanner will be, you'll have positive return from it. So I don't think it's something to wait for. The question always is, and I mean, even if you think of like the simplest thing, my phone, I have like, my phone is broken. And now when I think of buying a new one, I'm always thinking, should I buy it now or should I wait, a few months until they release the new one? So I think that's just an eternal, we always want the next thing. And sometimes it's worth waiting for the next thing if we know that there's going to be a significant paradigm shift in what's going to happen. I personally don't see any paradigm shifts happening. I think there's going to be incremental improvements to our intraoral scanners for the next, like I said, 5 years or so. And then if we're able to introduce new capturing technologies like ultrasound, that's when things will be different. But at this stage, the way that I would recommend someone gets into it is try them out first. Go to an exhibition, try out the different scanners, see which one's comfortable in your hands. After you choose 2 or 3 that you think are the right ones, ask the companies. I don't know if they do this in Turkey, but I assume that they do everywhere. Ask the company to bring in a demo scanner for a case. So if you have, it can be a study model, just a study model that you're taking for a patient, or a single crown case. Have them bring it so you try it on a patient to test and see what it's like. And it'll never be a good experience the first time. It's always going to be challenging. But if you try the 2 or 3 favorite scanners that caught your eye, you'll get a sense of which one, like you said, has the better software, which one has a better user interface, which one you're most comfortable with. The size of the wand makes a difference sometimes. So there's a lot of things you'll feel once you start to use it.
It's just we shouldn't rush to select or pick one of the scanners to buy. We just have to do a demo, as you said, and maybe for a month for each of them, for 6 months, just to research, make the correct selection, and then buy one, and don't rush. One of the questions was on the screen that popped up. Is it more important to stay in the same brand of impression devices, or should we choose the most accurate one or more accurate one?
If I understand the question correctly, do you mean by the question?
Like you have an Omnicam, and you will switch to PrimeScan maybe, or a Trios 4. Like, is it better to buy a PrimeScan or just go for Trios 4, let's say?
Okay, so if you have an older model and you want to get something new, should you stay in the same
same brand?
Yeah.
Or like,
if you're comfortable with it and you've already built your network around that, so in other words, you have, let's say, if you have other augmenting things, like you have a CEREC milling machine or something, and they talk to each other seamlessly, then I don't see a problem with that. There's no company that has such a clear advantage that I would say, no, you're better to buy this. All of them work well. All of them do a good job. Once you get good with them, you'll get the good results that you're looking for. Another way this question can be viewed is it better to stay within the same system in terms of, if my lab uses 3Shape, do I need to have a 3Shape scanner? And the answer is no. All scanners will give you an open source file, which is called STL in most cases. Right now we're starting to see things like PLY files and so on, but most of them are STL files. That being said, every scanner, 3Shape, CEREC, all of them, they'll produce a file in a proprietary format. And then inside the machine, they'll convert it from their proprietary format to STL. Studies have shown that anytime you convert a file, you lose some of the details in the file. I would still say, though, all the studies show that it doesn't make a significant difference enough for us to say, if you're using 3Shape, make sure you're sending it to a lab that's using 3Shape. You can be using a MEDIT scanner or a CEREC scanner and then exporting an STL file to a lab using a 3Shape design software, and clinically, those differences in, let's say, resolution of the files will make no difference based on all the studies that are out there so far.
Do you think like sending not an STL file but a colored file will change or will make any change on your restoration level, that it will improve your skills or improve your results in the end? What do you think about this?
Yeah, I think it does help with one thing that's very significant, which is one of the most challenging things with intraoral scans compared to PVS. The thing that I think is a big disadvantage is, with a model, it's a lot easier to see the margins because you're in 3D. You can feel it if you want with an Explorer, so you can very clearly tell this is where the margin stops. This is where the soft tissue starts. With digital impressions, that's very challenging, in my opinion. And I think if you talk to anyone who designs crowns or tries to mark margins, they'll find it much more challenging to identify exactly where that margin is. That's where color comes into good use, because with color, it adds some detail for you to be able to identify, okay, this looks like it's where my soft tissue starts. This is where my gums stop. But in addition to color, HD photos. So some scanners allow you, after you take your scan, they allow you to take close-up photos of the prep. Those photos have no use whatsoever in the design process, except for one thing: for the lab technician or the clinician who's doing this to overlay that photo onto the scan and get some more detail when marking the margin. So there's definitely advantages in being able to transfer that information to the lab during that process. Another thing you can do is if you're transferring, because what you said is a very good point. As soon as you transfer an STL to another format, a lot of times you'll lose color, or in some cases you'll lose color. So one thing that you can do is almost all the scanners allow you to mark the margin before sending the STL file. And that's something that's useful, because if you think the lab is going to have a challenge identifying the margin, you've just prepped the tooth. You're much more likely to know where things are. So you can use the software to mark where that margin is and then send it to the lab. So then the lab follows your marking as to where the margin is when they're fabricating the restoration.
I find this very important, that if you have a connection with your lab without any distortion, like a software which is combined like tree shape in the lab and in the clinic as well, or Serec with Sirona, that the file type that which is closed version will have all the data and will be sent to the lab, and this will be give much more. I feel more confident about it, more comfortable about it, and have let's say I feel more relaxed in the end.
Yeah, you're sending 100% of the detail. That's a fact. That's 100% true. When you're doing that closed system method, you're not losing any of the information.
Before my final question, I will just ask you, which type of retraction do you do? Like cords or pastes, or why you choose them? Or without any retraction, what do you think? Like, do you take any impression without retraction?
Well, if I have supragingival margins, then yes, 100%, I don't do any retraction. Again, I think of it as, especially if we're linking this to digital impressions, it will get what it sees. So I look at it and say, I need retraction or I don't need retraction. If I can see my margins clearly and they're supragingival, I won't use any retraction. If they're equigingival and I just want to create space, then I'll use a single retraction cord technique. Most of my larger cases, my go-to is double cord technique. So I use a 000 cord, and then on top of that, I'll use a 00 or a single 0 cord. And that's my go-to. I've recently, I'd say maybe 6 to 12 months, been using retraction paste to do one of two things. Either to replace my second cord, so I pack my first cord and then I use that as a second retraction method, or in addition to my double cord technique. So sometimes I'll do double cord plus retraction paste.
Too much retraction, maybe.
Yeah, that's a lot of retraction. But the reason, those are the cases. So for me as a prosthodontist, I get a lot of redos. Very rarely am I prepping a clean tooth. So most of the cases, they're crowns with already deep margins or subgingival decay. So I do a lot of deep restorations. And for those deep restorations, I found it very effective to use the retraction paste as a hemostatic tool. So to be able to control bleeding more than anything else. So that's when I'll combine it. But to me, it's really a combination of the different techniques depending on the specific situation. What do you use? What's your go-to?
I'm just a cord guy. I'm just used to it, so I'm not really a fan of the
single cord
paste.
or double cord?
Single cord mostly, but if it's really a deep margin or just how I have to elevate everything, then the double cord is always there. But I usually go for single cord. And for the pastes, which I don't like, mainly that I don't feel it will be cleaned properly. Like I feel always there is some sort of like a paste still there, but this is just a feeling, of course. But I like the cords, that the feeling that I push it slowly to the sulcus, that I like the kind of feeling that which is giving me the cord.
Yeah, the nice thing about digital impressions is you can't lie to yourself. After you take the scan, you can zoom in and you know right away, I had enough retraction or I didn't have enough retraction. So that's a nice thing about the instant feedback that you get. And in the end, if you're able to capture your margins with 3 chords or 0 chords, as long as you capture your margin and don't do any irreversible damage to the soft tissue, then then check completed.
Yeah, definitely. So what will be your final tips and tricks for the users or for the ones who will start digital impressions?
Final tips and tricks for those who are starting, I would say number one is choose your cases properly. Initially, one thing that I think a lot of people fall into, which is an error, is they focus on the time. In other words, if you're starting your scan, like you said, review your scan. And if you find that there's a certain area that is unclear, trim it away and rescan it. Take the time initially to perfect what you're doing, because then you'll get the comfort of the fact that it works, after which you'll become faster. So over time, you'll get better, you'll get faster. But initially, take the time to do it. But at the same time, I'll combine that piece of advice with less is more when it comes to digital impressions. So getting closer to perfection does not mean scanning the same area for 2 minutes, because what you're doing then is you're introducing so much more error with the stitching. So once you feel like you've captured an area accurately, you never have to go back to that area. I know a lot of beginners, and I was one of those. Wanting to be comfortable, you find a little tiny spot on the palatal area of the gingiva, for example, that has no, problem
Meaning
whatsoever
at all.
in terms of your restoration. Yeah, and you'll go back and you'll spend the time to dry it and find the right reflection to fill it in, because we want to see a beautiful filled in scan. Try to avoid that sort of mindset, because that introduces errors that are not required. Make sure you're capturing what you need accurately. You need to capture all the teeth accurately because of the bite registration, but don't pay attention to those details that are insignificant, and don't go back and forth when you don't necessarily need to, because keep in mind, the more you're stitching, the more errors you're introducing, the larger the file, and the more likely there are going to be problems along the way.
Very well. There's one question that which denture materials that or denture technique that you like to use, additive manufacturing or subtractive manufacturing for nowadays?
Yeah. Milling, which is subtractive manufacturing, is what I use most of the time. So we use the Ivoclar digital denture system, and so that's a milling technique. It has always been for the past, because digital dentures have been around commonly around for 5-6 years, so they're not something new. And for all of that time, printed dentures, which are the additive manufacturing technique, have had major problems being very brittle. If you drop it, it shatters like glass. They don't look good. They look very opaque. So they've had a lot of limitations. Milled dentures have also had a lot of limitations, but they've significantly improved over the past 2 years with the materials, with the burrs that are used in the milling machines. So I use a lot of milled. I do all of my dentures milled. That being said, in the past 6 months or so, there's been some amazing progress with printed dentures. So I don't know if you've heard of this, but the partnership between Dentsply and Carbon is a very, very cool partnership for digital dentures, because Carbon is, I think, one of the best 3D printers that's out there. It's very expensive, but it's very good. And Dentsply has very good materials, and being able to combine those two has shown that we can get very promising results with 3D printed dentures. So my answer to that question is, today I think milled dentures are the way to go, subtractive technique. The future is 100% printed dentures. Yeah. And I think all restorations, the future of them is printed rather than milled.
Did you have the chance to use or try the iVotion?
Yes, I have. No, sorry, I haven't. I haven't had the chance to use it because it's still not approved in Canada. But I've had the chance to. I was presenting for Ivoclar on digital dentures in Chicago. There is a big meeting that happens there every year, and that's when they announced about iVotion. So I was there when Eric Kakucha, which is one of our DDI faculty members, he's an excellent denturist in Ontario, Canada. He has been beta testing it for them for I don't know how long now, maybe a year or so. And it looks very promising because that's the ideal scenario.
Yeah.
Monolithic, right? We know that whenever possible, monolithic is better because it's stronger. If you're able to overcome the obstacles of aesthetics and detail and all that with the monolithic technique, then that's the ideal scenario. So I think iVotion is a first step towards being able to have truly monolithic digital dentures.
Yeah, I agree on this one. I'm really eager to test it as well and see the results, but I think that's really a really nice solution what they did. Thank you, Faraj, for joining me and for today. I hope you don't have anything to do today, rest of the day, and you can just have a rest. But
yeah, it's a long weekend here. It's a long weekend, so even though every day is a weekend for me now, but it's especially a weekend because Monday is off today. But thank you so much, Sina. It was first of all great seeing you again, and second of all, thank you for having me on this. I think, like I said, I think it's great what you're doing to advance our profession. So thank you again for having me.
Thank you. I wish you the best luck with your institute, with your work, and everything that you are trying to achieve. And hopefully, we will talk you soon on other platforms just to talk. And hope we will see each other soon. So, dear guests,
so too, yeah.
Dear guests, we will be just closing our show for today. But on Friday, 4 p.m. Spain time, we will be with Dr. Kochman. I hope you don't just miss this show, and hopefully I will receive your questions as well. We will see you on Friday, as we said, and take care and see you soon.